we asked Bonnie and Georgia to come together and give us a perspective from the department's perspective and give some good examples of how to think about data, how to use data, and an actual real-world example. So both Bonnie and Georgia are in the Commissioner's Office at DPH. Bonnie is with the newly formed Office of Data Management and Outcomes Assessment, which definitely sounds very serious. And Georgia Simpson-May is the director of our Office of Health Equity, so obviously has a good deal of perspective and knowledge on the topic for the day. So I'm just going to turn it over to them.
All right, thank you, Ben. My name is Bonnie Andrews. I'm with the Office of Data Management and Outcomes Assessment at the Department of Public Health. I talk very fast, so I'll try to talk slowly. And I wanted to thank you all for coming today. It's really exciting that so many people are interested in data. I feel like normally when there's a workshop on data, people kind of like sneak out the back door and you have like 2 or 3 people who are really, really interested in numbers who kind of stick around. So it's good to see that so many people are here. It also speaks to how important data is, I think. Increasingly, people from many different backgrounds are finding the need to sort of justify themselves either to funders or making the case to do what they do. So I think that data can be a really, really obviously critical piece of doing that. So today I wanted to talk a little bit about data and also sort of the process behind collecting data. I was wondering how many people have seen this before, the results process relationship triangle? Okay, fabulous. So a couple of people have seen it. This is something that an organization called the Interaction Institute for Social Change uses as a way to frame working collaboratively together to get a result. And really what it is it's the fact that results, the process of getting those results and also the relationship building you do in that process are all critical components of working together to move things forward in terms of making decisions that you do based on data. As a data person, historically, I've worked as a data analyst and an epidemiologist. Before coming across this, I was very focused on the results. I was kind of like, well, yeah, sure, I can get you an age-adjusted rate. You know, here's your number. Like, what's the problem? Like, why do you need to do anything else? But over the years, I've really come to see that working together with different people, bringing different people together at the table, and sort of the process that you choose to get those numbers, the process you follow, who's around the table as you're making the decisions about what to collect, who's around the table as you're making decisions about what to actually do with that data, really drives a lot of the process, and it's really, really critical, actually, rather than just, you know, basically consulting with somebody to generate a report for you. For example, if you were to hire me to do a report for you on, for example, like the health of Springfield, I could generate, 300 pages in probably like a month telling you like the difference in diabetes rates, telling you the difference in different chronic diseases, but that would be my perspective on the health issues of Springfield. I don't live in the community. I'm not somebody who's affected by the different health issues that are going on in the inequitable access to health promoting environments that happen. And I'm also not somebody who's making decisions that are decisions based on that data. So my perspective isn't the most important perspective around the table in terms of what we should be collecting and how we're making decisions based on those results. So I wanted to kind of start off with that perspective here. So the other considerations at the outset of when you're going to be collecting data, before you're going to be thinking about what to collect, you need to think about what the purpose of your project is. So really sort of what are you looking to do with this data? What are you looking to show? Are you looking to improve your processes in your organization? Are you looking to demonstrate health disparities in a certain condition? Are you looking to write a proposal to get a new park in your neighborhood or something like that? Sort of what are you really looking to do? The other really critical piece of this is who is part of that conversation, because it's really important to sort of bring together people who are directly going to be affected by your decisions, people with different backgrounds and perspectives from yours in terms of these issues. So again, what are you collecting? What's the purpose of what you're collecting? And who is there to make the decisions about what you're collecting? Because the outcome of this, like whatever numbers you pull together, whatever stories you pull together, whatever, is going to be deeply affected by who is around the table. Because in order to get something in a report, you have to figure out what to ask. And sort of what to ask can drive a lot of the conversations, and it can drive a lot of the decisions down the road. So it's really, really important to create an inclusive process. So again, what will this data be used for, and who's the audience for this data is another thing. The representative did a really great job of talking about stories, because you're really going to want, depending on whether you're presenting for, say, like the CEO of a hospital, whether you're presenting for a representative, whether you're presenting for a community audience, it's kind of important to know who is your audience, how are you going to be presenting this. Is a PowerPoint slide full of numbers and figures and trends and things like that going to suffice, or are you going to need to get really in-depth, more subtle information about sort of the experiences that people are having that really illuminate those numbers? So again, that'll drive a lot of your data collection process, sort of figuring out what you need so that you're going to be able to have a good presentation, a really convincing presentation, and a really inclusive presentation for whoever you're going to be presenting it for. And then deciding what to collect is there's another issue in terms of you could collect everything under the sun. So there's also a process of figuring out what do you need to know and what do you want to know. And those are two very, very, very different questions, it turns out. Because basically when you're designing a survey, you could literally do something like a 200-page survey with every question under the sun, like chronic diseases, health behaviors, food access, things like that. But you really want to figure out what do you need to know, because somebody isn't going to want to sit there and take a 45-minute survey, and your data is going to suffer as a result of that. Somebody who's answering a question that happens at 40 minutes into the survey is really not going to be paying a lot of attention as they are at the very beginning. So whittling down your questions to what you need to know is very important so that you avoid that kind of fatigue in terms of who you're collecting data from. And then what you want to know, it's always nice to sort of throw in a couple of different questions, like in addition to what you need to know, adding on what you want to know is really important to sort of add a little bit more depth to that data. But again, separating the questions into need and want are important so that you minimize that burden of data collection. And also thinking about how you can obtain this information. So there's some information that's better put into a survey form, for example, asking somebody if they've ever been diagnosed with diabetes, for example, is like a pretty simple, straightforward survey question. Have you ever been diagnosed with diabetes? But asking how their experience of care has been when they visit a doctor might be a little bit different. You might want to know very subtle information about sort of like how you were feeling in your interaction with your doctor. Did you feel like you understood what the doctor was telling you? Did you feel sort of empowered by that encounter? And that might be a little bit more tricky to get to in a survey, because I feel like a lot of times people sort of leap to a survey as kind of the easiest, most straightforward way to get data, but it might not be appropriate for what you're really looking to get, because what you're really looking for is that kind of nuance of personal experience that's hard to get to in a survey. Like, you want to be able to follow that up with more questions, like tell me more about that, or how was that experience for you, or do you feel that way every time you go, things like that. Whereas having that in sort of like survey form, yes, no, might not tell you as much information as you really need to be able to understand the problem. And also, again, how you'll need to present this information, because sometimes when you're talking to people in focus groups, like you're able to kind of probe them, you get people talking to each other about their experiences. That can be really interesting information for stakeholders and for legislators and things like that, versus sort of, a very numeric presentation that you're doing in a different scenario. So again, thinking about how to obtain this information, how you're going to present this information is really important to be thinking about from the very, very beginning. So a potential way to collect data, you can use quantitative data. So you've got your rates of hospitalizations and emergency department visits, you've got your immunization rates, prevalence of chronic conditions in the community, rates of poverty in community neighborhoods, crime rates in community neighborhoods. These are all sort of numeric data that you can get at through different sources like the Department of Public Health, your local police departments, things like that. So just some numbers that you can use to back up your argument. And then there's also the health equity considerations. There are many, many more than are listed here on the slide. Here are just a few of them: race, ethnicity, sexual orientation, gender. Because another thing when you're looking at for quantitative data is you want to be, in order to be able to tell people, for example, like disparities by race and ethnicity, you need to be asking that in a way that's meaningful on your survey, or if you work for a medical center and an electronic health record, you have to make sure that you're asking that of people, because if you don't have information on that, then you won't be able to tell anything about disparities. It particularly becomes an issue in some cases when you're talking about sexual orientation, because for some national surveys, for example, sexual orientation questions were added more recently. So historically, it's been a little bit harder to get information on that if you're looking at a nationwide survey, although that has improved in the last few years. But again, like when you're designing your data collection instrument and you want to be able to show, all of this stuff, you have to think about how to incorporate that into whatever tool you're collecting data on. And again, some methodology considerations, so like how you're going to be presenting the data. Some things to show disparities that are really useful, trends, maps, and also age-adjusted data. Because age adjustment is a method you can use to compare two different, for example, cities with different age structures. So, for example, if you're comparing, for example, I guess like I'll pick like a really large major urban community and a really small rural community, you want to be thinking about, are the disease rates really different because the ages of the people living there are different, or is it different because there's truly some kind of difference? So those are some considerations that you might want to think about, is are the populations you're comparing in two different places the same? And again, this is an example of a trend chart that was in one of our reports at the Department of Public Health. This is people who reported fair or poor health by race and ethnicity. It's a little bit of an older chart. It came from a BRFSS report from 2007, the Behavioral Risk Factor Surveillance System, which is a statewide survey. And you can really see that it shows why trends are so powerful is it shows that persistence in disparities. You can see that there's a gap between Hispanic, Black non-Hispanic, and white non-Hispanic respondents, and that it persists over time, which is something that's really important to be able to show when you're talking about disparities. Because you want to be able to show the direction of the trend, like are things getting better isn't always necessarily overall, is everybody getting better? It's sort of, are the gaps between the people who are experiencing the highest burden of these health conditions approaching that of people who experience the lowest burden of these health conditions? So is that sort of like narrowing, is something that you want to look at. Another way is maps. So this is a map of Springfield neighborhoods that we did for one of our projects. And what we did is we sort of took census data and we aggregated it into all these different neighborhoods. And then we looked at people who were the percentage of residents in poverty in each neighborhood. Because what this was doing is it was a project where they were prioritizing healthy corner stores, access to healthy food. And what they were really looking to do is saying, can we approach corner stores that are in the highest poverty neighborhoods, basically, or like the neighborhoods with the lowest, and also in comparison, they were also looking at the neighborhoods with the lowest levels of food access. So really, when you're looking at a map, you can kind of see the city or town there, and you can sort of see the disparities by geography. And again, there are some resources for quantitative data if you're looking for numbers. There's a really great website that's put out by the Metropolitan Area Planning Commission called Our Healthy Mass, which shows some rates of chronic diseases by city and town. So if you're looking for information for your city and town, there's a lot of great information there. The department has something called MassChip, which used to be a system that you could download onto your computer and run data, but now we tend to post sort of instant topics, so you can go there. And Community Commons is another really great one that has sort of data for smaller regions, and you can kind of go there and create your own maps and things like that. So that's just sort of a couple of different resources for numeric data. And the other great resource that I wanted to put out there is the Department of Public Health. So I mean, we actually provide a lot of data for different communities, looking for data on different things. So, feel free to contact me. My email address will be up there if you're looking for any data, because actually recently I worked with some people, a couple of different stakeholders in Springfield. Ben helped me to get some data to people because they were actually looking to produce a health equity report, which was really exciting. So that's another thing. People, we're resources too. So another type of data collection you can do is qualitative data, and that tends to be, again, the conversations, the stories. You talk to many different people and you sort of see these themes start to emerge, and you might start to prioritize things differently as a result of talking to people. So you can do focus groups, which is sort of getting a bunch of people together, asking them questions, key informant interviews where you talk to sort of one person one-on-one. And then you sort of, generally what you do is you use the same script for multiple groups, and you get them talking to each other, different themes emerge, and then you can sort of say, the real concern among these groups of community members, for example, was lack of access to healthy food. Or because in a lot of cases when you actually talk to people about what they think the biggest problems in their communities are, it's much different, again, from what I would think the biggest problems in the communities are looking at the numbers alone. So this is a really important piece of data, as well as being able to present that to different people. So again, some of the health equity considerations, not all of them are listed here, making sure that they're multilingual and multicultural, that they're conducted in different languages, how you recruit for them, the timing of the groups, like people might not be able to make them during the day if they work, or you might want to hold them earlier in the day if you're looking at different people. So again, looking at who you're looking to talk to and when they're available, and sort of making that very person-centered or population-centered to make sure that they're available when you need to talk to them. Building rapport, so like, when somebody gets really comfortable with you, they're gonna tell you a lot more than, if you're just kind of firing off questions at them, so building trust is really important. And also, again, the questions asked are really, really important in this, and this is where it's really critical to have people around the table from all kinds of different backgrounds, representing all kinds of different organizations, because the questions asked really can drive what you find out of these focus groups, so really making sure that all of those perspectives are represented. And sustainability considerations are important for qualitative data too, because, for example, you can bring in a consultant to do focus groups and key informant interviews, but what's really helpful I've found in different projects I've worked on is actually training people to do, people within the community to do them, because then if you want to find out more information or you want to go back and do another project based on what you found the first time, there are people in the community who can already sort of go out and do that, and you have that capability within your community. So something that's really important to consider for qualitative data collection. And again, decision-making is the most critical part, creating an inclusive process for decision-making based on the data. So who is sitting around the table to make the decisions based on your data? And again, it doesn't really matter whether it's an internal organizational decision, whether it's an external decision. It's really important to think about who you want at the table and whose voices that you need represented in order to make sure that it's an inclusive, equitable process to prioritize and sort of drive resources towards whatever you find the biggest needs are. And also, planning for report back to the people who participated in the data collection process is really important too. Like, I've done focus groups in communities where people literally came up to me and were like, can I have your card because I want to make sure that I know what the results of this report were, when like, they want to make sure that that what they participated in, they know what the results of it were and what's being done with the data. So that's something that's really important too. And now I'm going to turn it over to Georgia Simpson May to talk a little bit about a real-life experience where they had to make decisions about data in a very short period of time.
Thank you, Bonnie. So, of course, I love and appreciate data, but I like telling stories even more because behind every number is an actual person. And we have to keep that in mind when we produce information on populations, that there are people behind these numbers. So, anyone remember H1N1? Only 5 of you? Come on. Okay. I hope so. That was a major event. And it was major in Massachusetts as well. And we have, as a result of it, a real-life story of watching health equity being achieved in real time. And I'm going to take you, hopefully, through this story. So, immunization trends, flu vaccine specifically in Massachusetts for adults age 65 and older, tended, as Bonnie said, to, although improve, sustain the gaps between white, Hispanic, and black. That's not something you want to see. When you're looking at equity, you want to see the trends or the trend lines converge. You want to see populations coming closer together, everyone improving. A little bit more data. Now we get into H1N1. And I'm not going to deep dive into this, but just to simply show you the differences in hospitalized populations in Massachusetts and the Massachusetts population in general. So as a result of H1N1, we had, for example, black non-Hispanics hospitalized at greater rates than their representation in the Massachusetts population. Same for Hispanic as well as white non-Hispanic. That diagram, that image is reversed. There were fewer hospitalizations as related to the size of population in the state. Rate of hospitalization, again, by race and ethnicity. And we see huge differences by black, non-Hispanic, Hispanic, and white, and Asian. And this is just what's kind of set the context for us, what was happening. This information was captured very rapidly. I think one of the great things that the department does very well is surveillance. And our surveillance data was telling us an unsettling story, that there were populations disproportionately impacted by H1N1. So it was on the scene. There was a press release, January 15th, also my birthday, where, honestly, feds came in. We had the governor. It was a big deal. Massachusetts was going to declare or share with the country its approach to addressing H1N1 as seen in the state. We identified the racial ethnic disparities. We knew there were populations that we needed to focus on in particular. Again, not to take away from the good work that was already being done as a whole with respect to population health, but there were populations that needed focused attention for various reasons. All the things that Bonnie mentioned, whether it be language, whether it be approach to healthcare, whether it be being part of the healthcare system. So federal CDC came in, Centers for Disease Control and Prevention. They had provided states with significant dollars at that time to really address H1N1 through pandemic preparedness. So we worked with our Office of Emergency Management to do some of this work. And they then, in part, within the department, through the commissioner's directive, allocated resources for us to address H1N1 that was affecting racial ethnic populations in Massachusetts. So we had a plan. We wanted to engage the organizations that could reach the populations. Through the Office of Health Equity, we had already had some health disparity reduction grantees. We were very fortunate to have those groups, community-based groups, doing work in very innovative ways to share with us how to approach health equity, how to reduce or get to the populations experiencing disparities. And so through our health disparity reduction grantees, we were able to fund a portion of them to really get to the populations that were low vaccinating, the ones that weren't being reached, the ones that weren't being communicated to effectively, the ones we were having challenges helping. And so I think what's important in this scenario is that the learning has to be on the part of the department. It's not that the population has the problem. We may have challenges in reaching populations. And when you understand that and you come from the approach of we need to partner with those who do it better sometimes than we do, then it's a win-win all around. And this is one of those situations where we took the approach where we needed to learn better how to reach populations in flu vaccination. So overall, the goal of a small initiative that was launched, it was a 4-month initiative. We had very little time, literally, to get money out the door to the community-based organizations and for them to then do outreach, education, and vaccination. The intent, again, of the RFR was to increase vaccine uptake among low vaccinating populations. And then for us to support and encourage community-based partnerships, in particular with faith-based organizations that have significant inreach into communities. And then we also worked with a consultant group that could provide the TA necessary to ensure that commercial vaccinators were communicating and connecting with community-based organizations, and that they were going to the places that the community-based organizations said you will identify and reach the population most in need. We did, at the end of the 4-month period, we had a lot of information, a lot of data, which was good. We also had a lot of stories, which was even better. And we asked the 8 funded organizations to come in and share with us their experience. We actually said to them, tell us what we didn't do well. Tell us what DPH did not do well. They're like, are you sure? We're like, yes, absolutely. This is not punitive. We want you to be as honest as you can be. And they were. So, and that was a good, again, the communication is key. Opening up and giving permission almost to say, yes, be honest, let us know how to do this better. And so they said, you know, we need to work locally with local boards of health, with public health nurses, on how to connect with community-based organizations that have been working in the communities for some, you know, many generations, that have the relationships, that what we like to say, have the street cred, can go in, can talk about what the issues are, who understand what maybe some of the barriers, if not most of the barriers are, to people engaging in something like a vaccine initiative. Increase efforts to include youth. Youth have a very different perspective than most adults do around how to talk to other youth and how to engage them in community health approaches. And they were very creative. I have to say, we worked with one group of outreach workers, community health workers, and they went to the basketball court. And one of the community health workers who had been vaccinated, was talking to the group of guys, and he was like, when I got my vaccine, I was able to jump higher and get that ball in that hoop. Whatever it took to at least get people listening. Would I have ever thought of that approach? Probably not, And so it's really respecting and understanding the expertise that can be brought into a system, a public health or healthcare system that comes from outside of the four walls that we tend to sit in. Have community champions. That person was a community champion, clearly, because people listened to him. And support the development of community-wide coordinated and written plans. So one of the things we asked them to do was to please document as much as they could without us, being overburdening them, because you can do that as well. But really to help tell the story, share the story, so that we could potentially replicate and do well in other communities. And also not for just flu, but maybe other public health emergencies that come around. As a result of all that work for the year, we sat at DPH and talked to also some of our external partners, and we were like, this isn't a one-off. Flu comes every year. Other emergent issues may crop up. What is it that we're looking to do as a result of this? And we formed an immunization equity team, looking at flu and other vaccine from 2010 and beyond. So here we are, 2014. And we are definitely still engaged in this process. Some of what we learned is that, again, forming the team and having the right individuals at the table is critical. So it wasn't just DPH, it included Mass League of Community Health Centers, folks who operate the Massachusetts Adult Immunization, not council, but it'll come to me. Coalition, that's it, that's the word, coalition. And then MassPro, who also is significantly involved in adult immunization practices. We took the lessons learned from the H1N1 flu pandemic to inform future flu and other vaccine efforts. So what are some of the things we should do? We should say, okay, we know that there's a persisting gap between populations. I showed you that chart. How do we reduce that? What are some of the expectations that we need to set for ourselves with respect to reducing that? And so we put out there things like reduce by 10% the rate of, or increase by 10% the immunization rates among low vaccinating populations. And given the surveillance information we had, we knew it was primarily African American males aged 18 to 49. So we had a focus, and we could engage communities in addressing the needs of that particular population and increasing vaccination rates among that population. And then, again, as I mentioned, set the goals. The goals were not set out of the blue. They actually relate to the Healthy People 2020 objective. Are folks familiar with Healthy People 2020? What have I, okay, very good. And so we wanted to be consistent with what was happening nationally and some of the expectations. And know that Massachusetts is pretty high up there in terms of its vaccination rates, but we're not at 80%. So there's still work to be done. So what happened? Conversations, they told us what we needed to do. They said we needed to work with local boards of health, public health nurses, share the experience so that they could better engage in future efforts with community-based organizations. And as a result, we developed a flu guide, and it's called Flu Vaccine for Everyone, a guide for reaching and engaging diverse communities. Why do we need to do a guide? Now, it's about yay big. That's about a half an inch. But it's very clear about how you engage diverse populations in their own healthcare and in the systems of healthcare. Having individuals at the table, having diverse perspectives represented, everything from school to the barbershop to the charlas or the promotores or whomever is in your community that is a stakeholder, that is a gatekeeper, are very important to your and our efforts. This guide, as I mentioned, started with the community-based organizations telling us what we needed to do. We asked them what should go in it. After that, we then shared it with about 20 public health nurses, and we asked them to give us their opinions. And they did, and they've been incorporated and integrated into that. We then shared it with a few local boards of health, and we said, how does this feel to you? What are we missing? What's not quite right? And they shared with us as well. So there was a significant participatory process going on here, and one that we replicate time and time again to ensure that we're getting it right and that it makes sense. By the time the document came out and we shared it more broadly, the public health nurses said to us, this isn't a guide about flu vaccine, this is a guide about community engagement. This could be applied to almost anything you want to do as it relates to public health and communities and making that connection and linkage. In addition to that, this guide was made we did this for our 351 cities and towns in Massachusetts. We wanted to support their efforts in reaching the populations that traditionally don't simply come through doors, for various reasons. But for us to go out and be able to connect with communities. Our CDC project officer asked if she could share it internally, and lo and behold, the guide went viral. And I like to say that because it was flu and, viral, okay. And so the guide went viral for real. It ended up as one of the resources for the CDC's national flu campaign. And they do it every year. So we were very happy, needless to say. What was I explaining through this whole thing? It's one of the things that we like to try to frame our work upon, and it's the Plan, Do, Study, Act cycle. It's about continuous quality improvement. We want to continue to improve upon what we're doing. What we did with the plan is that we identified the priority populations and engaged the populations, developed goals and strategies, identified the resources and the partners. Then we started doing. That's when the partners went out and they did some education, outreach, vaccination, and all those things happened and collected the information for us. Study. Well, let's take a look at this. What is it telling us? That's the Learning Lab. And then we acted upon it. We adapted and published lessons learned and best practices, and hopefully developed some standards of practice. Now, we've been doing this for a while, and we're continuing to do it as we speak, which is a great testament to that particular work. So what happened? Everybody wants to know, so what happened? Okay, fine. So what happened? Hello, friends at OHE. For the 2011-12 flu season, 51% of white residents 6 months and older received flu vaccine compared with 48% of blacks and 51% of Hispanics. The rate for blacks increased 6 percentage points over the 2010-2011 flu season. The difference between flu vaccine rates for whites and blacks in 2011-2012 was only 2 percentage points, down from 10 percentage points the previous season. We don't know why this is, but I think all the work you did with the CBOs around this certainly helped. Yay. Thank you.